Hey guys, Floyd here with the Curbside to Bedside podcast. Today let's talk a little bit about end-tidal CO2. I want to talk about this because although it's been espoused for a while, many people still mess it up. Specifically, I want to cover the basics about how the patient's physiology determines the numerical end-tidal CO2 measurement, and also discuss some of the technical aspects of monitoring waveform capnography. Now, while I was in the process of scribing for this podcast, the folks over at PHEM put out an excellent, in-depth review of this very topic. After listening to this, please go on to our site and follow the link to their podcast. Capnography gives us a graphical and numerical representation of the concentration of carbon dioxide in the expired gas that comes from the patient's alveoli during expiration. There are two common ways of measuring end-tidal CO2. One is via an inline device that's either placed on the ET tube or between the BVM and mask, and the other is via a nasal cannula that's been adapted to measure end-tidal CO2, and we're going to refer to this as Sidestream. One of the worst cliches in capnography teaching is that the end-tidal CO2 that we measure in the pre-hospital field is somewhere between 3 to 5 millimeters of mercury, less than the patient's arterial CO2, and some adhere to that belief and want to try to adjust the respiratory rate or minute ventilation based off the end-tidal CO2. Doing this can kill a patient. In the patient who has normal lung and heart physiology, meaning normal perfusion to the heart and lungs, this is somewhat close to being true, but these are patients where clinical utility is limited in the pre-hospital field. Even in a normal, healthy patient, the end-tidal CO2 will still have a lower end-tidal CO2 than the arterial measurement. End-tidal CO2 will never be higher than the arterial CO2. And to understand this disparity, we must first understand a bit of pathophysiology. But simply put, you can't have a higher concentration of CO2 in the lungs than in the blood, because the CO2 in the lungs comes from the blood, and in the majority of our patients, the cardiac output or lung perfusion is disrupted. So you'll have less blood coming to the lungs, therefore less CO2. The relationship between end-tidal CO2 and arterial CO2 are lost or has a higher discrepancy between the two when there's what we call a ventilation-perfusion mismatch, often referred to as a VQ mismatch. This occurs when something interferes with the ability to get either air or blood to the alveoli. Now, there are two types of VQ mismatch. The first and probably most important to end-tidal CO2 is dead space. Dead space is when the lungs are able to be ventilated but not perfused. The second and less applicable to end-tidal CO2 monitoring is what we call shunt. Shunt occurs when the lungs are perfused but not ventilated. The stereotypical example of dead space occurs in a patient with an acute pulmonary embolism. The dead space increases because all lung units are ventilated, but only some are perfused. This will cause your end-tidal CO2 to be significantly lower than your PaCO2. Theoretically, a 50% reduction in pulmonary blood flow would result in a 50% reduction in end-tidal CO2. Let us consider a patient who is in cardiac arrest. A decrease in pulmonary blood flow caused by the lack of cardiac output leads to a decrease in your end-tidal CO2. This is why during a cardiac arrest we use end-tidal CO2 as a marker of chest compression quality and also to assess for a return of spontaneous circulation. If, say, during the resuscitation we see a sharp increase in our end-tidal CO2, then we can anticipate ROSC during our next pulse check because the most reasonable explanation for the increase in end-tidal CO2 is an increase in blood supply to the lungs when the patient's heart starts beating on its own. So you should be able to see now that anything causing poor perfusion to the lungs, whether it be a pulmonary embolism, cardiac arrest, sepsis, and nearly every form of shock can cause a lower numerical end-tidal CO2 value than is actually represented in the patient's arterial CO2. Knowing this can help reduce errors that occur when we try to treat the numbers rather than interpreting them in light of the patient's underlying physiological state. This knowledge is applicable to many areas of pre-hospital medicine. It has been espoused to use end-tidal CO2 to determine fluid responsiveness, to verify mechanical capture during transcutaneous pacing, to use as a marker of chest compression quality, and also as an adjunct to sepsis screening tools. As you can see, end-tidal CO2 offers more applications when it is used as a marker of systemic perfusion. Recently, the AHA released a statement on cardiopulmonary resuscitation in adults and children with mechanical circulatory support, aka mechanical assist devices, such as the LVAD. With LVADs, you're only able to obtain a non-invasive blood pressure about 50% of the time in patients with a continuous flow LVAD. Therefore, when assessing flow and perfusion in patients with these devices, waveform capnography can be used in conjunction with your clinical assessment as an indicator of perfusion in these patients. Now that we've talked a little bit about the physiology, I want to discuss some technical aspects of end-tidal CO2 monitoring in the pre-hospital field. First and foremost, we should know our equipment. You have to know how to connect it to your monitor and turn it on so that you can see both the waveform and the numerical value. On some monitors, you have to physically push the button on the monitor to begin measuring end-tidal CO2 after you attach the filter line. On others, it automatically begins measuring once you attach the filter line to the monitor. After that, you've got to be able to see the waveform in addition to the numeric value. On some monitors, this appears immediately on a monitoring lead when you turn on the end-tidal CO2 monitoring. On the LifePak 15 monitors that I personally use, they are configured so that once you attach the filter line, you have to go and select a monitoring channel and change it to monitor the CO2 waveform. We all know that waveform capnography is the golden standard for ET tube verification. But is there any value in using the colorimetric device prior to placing the mainstream device? I believe that the answer to that question is no, and there's two reasons. The first is that the waveform device should already be hooked up and ready to go, because prior to intubation, we generally use a bag valve mask to ventilate our patients. And any time we do this, we should be measuring end-tidal CO2 to both measure the effectiveness of our ventilations, because we can assume that if we have a measurable end-tidal CO2, that the airway is at least somewhat patent. And two, the colorimetric device requires generally at least 6 breaths before you can verify tube placement. With waveform capnography, you should know within the first few breaths, as long as you have a good solid waveform and numerical value, that the tube is in the right hole. So simply place the mainstream device between your bag and your mask anytime you're performing BVM ventilation, so that once you place an advanced airway, all you have to do is disconnect it from the bag valve mask and place it on the end of your tube. Now, if you're wanting to measure end-tidal CO2 non-invasively using the Sidestream nasal cannula, there are a few more technical aspects you should know. The first is that the Sidestream Cannula is not a great oxygen delivery device. It's fairly good at measuring end-tidal CO2 if we take into consideration what we previously discussed about physiology, but it's not good at delivering oxygen. There are multiple different manufacturers of these devices, but the one I've seen most commonly used in my area has a scoop that comes around the mouth, and if you look above that scoop up between the nasal prongs, you'll see these little fenestrations. Those little fenestrations are actually what delivers oxygen, not the nasal prongs. The fenestrations are supposed to create an oxygen cloud, quote unquote, and the prongs are what samples the CO2. A paper that we've linked in the show notes by Thomas Ebert and his colleagues found that this supposed oxygen cloud delivers less oxygenation than does a standard nasal cannula. However, the nasal cannula that is supposed to deliver oxygen via the cloud, I think, has since been redesigned, and I'm sure that the manufacturer will say that it performs as well as a standard nasal cannula, but anecdotally, I have not found this to be true. What I currently do and recommend to others, if you want to provide oxygen to your patient via nasal cannula at flow rates greater than, say, 2 to 3 liters per minute, simply place a traditional regular nasal cannula over top of your end-tidal CO2 cannula. This may or may not cause a washout of some of the CO2, thereby lowering your numerical values. But if it does, you can at least get your baseline before you put on the additional cannula, and then periodically turn off the additional nasal cannula to obtain readings. This may or may not be worth the trouble, but I'd do it. Give it a shot and let me know what you think. The last technical aspect that we're going to talk about is how to accurately measure end-tidal CO2 during non-invasive ventilation. The most reliable way to trend end-tidal CO2 during non-invasive ventilation is by placing the CPAP or BiPAP mask over the end-tidal CO2 cannula. A study done by the Department of Respiratory Care in Boston found that this is the most reliable method, and I've seen this in my own practice as well. That's all for now. Thank you for listening to the Curbside to Bedside podcast. If you have any questions or comments, we would love to hear them. Feel free to drop a line in the comments, email us, or find us on Twitter using @CurbToBed. Have a great day.